بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. On behalf of the Saudi Society for Rheumatology, it's my sincere pleasure to welcome you again to the second night or second part of Best of EULAR webinars. Yesterday we have mentioned that the annual European Congress usually is a good plate for a lot of scientific information and a lot of new researches, for which we did this Best of EULAR to share the new researches and to summarize or highlight the update in guidelines as well as in most of the studies. Yesterday, alhamdulillah, we received a very good response from our colleagues regarding the program and speakers and the information. And tonight, inshallah, we will have a very interesting topic. It will be excited about systemic lupus erythematosus, about vasculitis, scleroderma, mixed connective tissue disease, and so on. As I have mentioned, tonight we will have 3 sessions. The first session about systemic lupus erythematosus. Just didn't share with you the slides. Few things. Yesterday we have a comment regarding, though it was very clear screen, but some of my colleagues, it wasn't clear with them, maybe because they are using the mobile or the internet was not strong enough. So we prefer to use Chrome as well as to close all VPN and connect directly to the internet in order to have a clear webinar. These are the sessions for tonight. Just to remind you regarding the question, you can find in the right part of your screen down an arrow where you can write your questions during the webinar. So at the end of the session, we'll try to answer all of these questions. Now we'll start our first session about systemic lupus erythematosus, and our first speaker, he's one of maybe few, not much, because he's a new consultant. He's an excellent, actually, colleagues, Dr. Ibrahim Al-Maghlouth from King Saud University. He's an assistant professor rheumatology in Department of Medicine. He's an assistant also director of College of Medicine Research Center at King Saud University. Dr. Ibrahim actually is having 2 boards, the internal medicine from Canadian as well as he got the American board. The same for the fellowship rheumatology, he got both the American and Canadian, and he's having also subspecialty in systemic lupus erythematosus. Also, he's having a master in epidemiology. He's very active in the research part as well as a teacher. He is also having a lot of publication, and now he is holding a good position actually in King Saud, which is about registry, which is related to King Saud. And the good news that I have to inform all of our colleagues in Saudi Arabia, that is the Saudi Society for Rheumatology established now a registry for rheumatoid arthritis as well as systemic lupus erythematosus and spondyloarthropathy. And we wish that all rheumatologists in Saudi Arabia to be part of this registry, so we will have our data, our researches. Just for no more delay, we want now Dr. Ibrahim to take the microphone and to start his lecture about the renal part of systemic lupus erythematosus from EULAR 2020. Welcome, Dr. Ibrahim.
Thank you so much, Dr. Hanan. I'm humbled with your introduction. I'm not sure that I deserve all of this, but I hope that this talk highlight a couple of things related to lupus, and enjoy the wonderful year of they call it the year of the wolf, just because of the breakthrough in lupus research over the last year. We'll spend some time in some of the definitions, so bear with me, and please ask questions perhaps at the end of the day, where we can actually shed some light regarding the details and the reasons of variation in the results. So we'll move forward. The journey of lupus research, particularly related to lupus nephritis, is very interesting, and to keep it more exciting, we'll start with one of the important trials, and then we'll end with another important trial. So if you have something to do in between, please come back at the end. Moving forward, so obviously this year was full of a lot of information related to lupus nephritis. And one of the major organ involvement in lupus, as you all know, in terms of morbidity and mortality, especially in the early phase of lupus, is lupus nephritis. Now, about 40 to 50% of all lupus are estimated to have a lifelong risk of lupus nephritis. So about half of our patients will end up having some sort of lupus nephritis throughout their disease. And because of that, it's considered to be a very important target of therapy. So far, before this year, we had 50 years of having no effective approved treatment for new treatment for lupus nephritis. And this year, we had a couple of. So let's go through them. So the first article article that we'll study, that we'll start with, is the EULAR update of 2019. And the reason why we start with the update, because this is everything that we know about lupus nephritis in terms of evidence-based treatment before the EULAR. So this is where we start, and this is where the base knowledge that we carry on further forward. Now, most important part of this, EULAR has consistent guidelines for the update of management. They use something called Delphi technique to ensure to generate common ground for important questions related to lupus nephritis, and they look for the evidence that address these questions. So the first part in the lupus nephritis is definition of response, and you will see that one of the most important reasons of why we have different results from different treatment is the definition that we use to say someone has a response to a treatment or not. Now, bear with me, even the same term, for example, complete renal response, may vary over time and from a study to another study. So the first thing that they highlight in the EULAR update 2019 is that complete response. And what they mean by complete response is that your protein, 24-hour protein, then between 0.5 to 0.7. Now, this is very important because the initial definition of complete renal response was less than 0.2 or sometimes 0.3. And now they realize that because of the accumulated evidence that within 1 year, the best predictor of long-term outcomes of lupus nephritis is less than around 0.7. So they said between 0.5 to 0.7. Now, and this is very important, with normal or near normal GFR, so close to the upper limit of normal by 12 months. So your eGFR should be close to normal within 12 months, and they sometimes include in that definition absence of active urinary sediments, i.e. they should not have WBCs or red blood cells cast or whatnot. But here, the two more important things is creatinine level and the protein. Now, they also recommend, of course, Plaquenil. Hydroxychloroquine is important with ophthalmological check. The reason is the evidence of Plaquenil reducing the number of flares of lupus nephritis, and there is more into that. We'll not go into the detail of this. They also talk about the induction and maintenance. Highlight of what we already know: induction with either MMF 2 to 3 grams per day versus the EULAR Euro-Lupus protocol. So that's the 500 milligram IV Q 2 weeks times 6. For induction, and then maintaining the treatment with either MMF or Imuran, and again they stress, which is very important, they stress on low dose of a steroid by 6 months. So by 6 months you should not be on high dose of steroid. By 1 year you should be less than 7.5. The second part in the recommendation, I think we should highlight this, is where we see the rituximab in the treatment regimen. For those who have they do not respond as we wish by 12 weeks, by 12 months, then they would consider the addition of rituximab, and this is a very important highlight from their point. The other thing is pure membranous. We know that there is a lot of discussion about whether you treat a pure membranous lupus nephritis, so class 5, whether you are a rheumatologist, you will treat. If you are a nephrologist, you are not. The EULAR, which is a combined by rheumatologists and nephrologists, they would recommend the treatment of lupus nephritis class 5 if you have nephrotic range proteinuria, so that's more than 3 grams, or you have proteinuria of more than 1 gram despite the use of ACE or ARBs. And the treatment here, they would recommend MMF plus steroid. Remember that there was a trial of trial of membranous nephropathy, not in the context of lupus, that was positive for rituximab, but that was not highlighted in the EULAR recommendation. Now, the last part, they will assess for comorbidities, extra-articular manifestation, and of course they would suggest the importance of transplantation as a renal replacement therapy instead of dialysis. So if you have the option, you would go for transplantation. The best time for transplantation is obviously before going to end stage, before you require dialysis, and that's one of the good predictors, but it was not mentioned here. I'm not going to go into the conclusion because we have a lot going on further, and we'll move to the second very interesting, very exciting news, the study of belimumab, which is anti-BLyS, which is B-cell lymphocyte activating factor in context of lupus nephritis. Now remember, we had BLyS trial that was positive for phase 2 and for phase 3 in context of mucocutaneous, or those people with active disease, but not purely lupus nephritis. And we had that was one of the breakthrough in the last 50 years. And then we had this specific study that looked at BLyS in the context of lupus nephritis. The study was a double-blind randomized controlled trial, phase 3, and essentially they tested the efficacy of IV, so that's not the subcutaneous, IV belimumab 10 milligram per kg in context of patients with active lupus nephritis as an add-on therapy to standard treatment. Now, I will recommend you to go into the details of the study, but what is very important, and here is the key component, what they want to show here is that they want to show that you are able to reduce the steroid after 6 months of treatment, because those people did not achieve their primary treatment target. So hence, they wanted to highlight that if you use belimumab, you would be able to lower your steroid by 6 months. So that's a very important target. And two, which is very important also, is the definition of response. One of the major reasons of lack of response in most of the trial is the definition of response. Now, their primary response was at 104 weeks. So remember, 104 weeks, we're talking about, that's the primary outcome. And the reason why they chose this long time to define outcome, because we know that belimumab takes a long time to work, and at least 6 months. So they want to highlight, they want to get the best shot. So about 2 years or so of treatment. Their primary response is called the primary response for what was going to say? Sorry. Got something like that. Yeah, so the primary response for the lupus nephritis here is called primary efficacy renal response. Now, what does that mean? Essentially, that means that you have to have a protein, a creatinine, a total protein collection, as highlighted here, of what was I going to say? So the protein collection should be in 20 for hour, should be less than 0.7, and essentially the key component, the other key component that they use for the definition is the creatinine level. So you have to have your creatinine eGFR should not be more than 20% of what it was on before the treatment. Now, this is very important because that highlights the difference in outcome from complete renal response, which is a secondary outcome that they use. So you have to have a protein correction, a protein creatinine ratio less than 0.7. So that's about 0.7 gram in 24-hour protein collection, and your eGFR should be within 10% of the before the renal flare, before the treatment. So it should not be more than that. Now, there are key components of secondary outcome, and the key outcome is what is the response rate at 52 weeks, and the overall response, so either partial response or complete response at 104 weeks or 52 weeks. And also they looked at 24 weeks. And finally, and this is, I think, a very important outcome, is time to flare. So if you start this treatment, would you alter the natural history of a flare-up in patients with lupus nephritis, i.e. you would induce remission and you have less flare-up over time? Now, the good news, well, the interesting news, they met all their primary and pre-specified secondary outcome. Now, remember, primary outcome is the most important, statistically significant ones. And I want to highlight one thing. Now, this is not a magical treatment. The difference between belimumab and placebo is about 10%. So that's 1 in 10 people of that if you treat, they will get response. So this is not a magical treatment. It's a good treatment, not a magical treatment. You just keep this in your mind. And also, I want to highlight in the secondary outcomes, the partial response does not differ significantly from both sides. Now, this is a secondary outcome, so post hoc analysis. The most important part is if you would respond to belimumab, then you're likely to have a very good response. If you don't, if you have partial response, probably belimumab is not doing a lot. But this is my own conclusion on this study. Now, this is a very interesting. So that was the first study. I think I'm going to run out of time, and Abdulaziz Khalaf is looking at me with a staring. So I'm going to try to wrap up quickly. A second study is very interesting and related to the last important study that we'll discuss later on. But this study highlights the use of calcineurin inhibitor, the second generation, tacrolimus, for lupus nephritis. Now, without going into too much detail, calcineurin inhibitor have two effects: either effect on podocytes, so that they reduce the amount of protein you spill, or immune suppressive effect, so immune modulatory effect, where they actually induce remission. Now, agents, they usually tend to use it a lot as an induction therapy. There was a this trial was done in 2007, around 2007 reported, which will compare induction using tacrolimus with steroid versus MMF and steroid. And essentially, they are reporting the 10 years long-term outcome. To make the story short, they don't seem to differ significantly, perhaps more proteinuric flare, so more increase in protein was in the tacrolimus versus MMF. They did kidney biopsy, and they did not find a lot of fibrosis in patients who had flare-up later on with tacrolimus versus MMF, because that's one of the concerns with the calcineurin inhibitor, i.e. tacrolimus seems to be a safe medication, has a good efficacy and good alternative long-term outcome, and that's should be highlighted in the EULAR as an option of treatment if people do not respond. Keep in mind, in this study they used Imuran as a maintenance therapy, which not necessarily the best therapy in my opinion versus MMF. Now, remember that later on, because we will discuss something about the third generation calcineurin inhibitor. Now, this is another study which is very important. Looked at that's essentially the same study. Sorry, I'm gonna wrap up quickly. I know look at Dr. Hanan is looking at me, so I'm just gonna move on. The third study, which was a very interesting study, was essentially analysis. And again, it's not the primary study; it's analysis for the obinutuzumab, which is essentially more specific anti-CD20. Some people say it's a remarketing of rituximab, but essentially it's an antibody to a CD20, more specific, has shared epitope with rituximab, works essentially more or less the same, but more specific, and that means less resistance and less failure with it. They use it more in cancer treatment. And what is interesting is that it was studied at phase 2 study for lupus nephritis and showed a positive result, and now they are in phase 3. And what they did here is they tried to look at the definition of outcome. Remember, we said one of the most important reasons why lupus nephritis medications in the trials, they fail or they have different responses, because the definition of the response varies from study to study. So what they did here is simply they changed the definition. They played with the definition. And what they used here, and they want to rationalize it because they used the more modified version of response in their clinical trial that is called Nobility, that is called Regency trial. So essentially preparing for, justifying to themselves. And definitely Roche will not hire me after this talk. But the key component here, see, they define complete renal response. See, the redefined complete renal response is the most strict definition of renal response. It requires that you have a total 24-hour protein collection less than 0.5 gram, or urine protein creatinine ratio less than 0.5%, serum creatinine close to the upper limit of normal, or less to the upper limit of normal, and it should not exceed usually 10% of the upper limit of normal. However, now if you modify this definition and you allow the serum creatinine to go up to 25%, i.e., your protein collection less than 0.5, your serum creatinine is close to the upper limit of normal, but before the baseline, before you go to lupus nephritis, it goes maximally less than 25%. Then you get a different definition of complete renal response, and the response rate change. For example, here in this Nobility trial, the response rate was 29%. If you change this small tweak, you get 43%. And this is very important because you can completely see how you can get a very positive study compared to another. And that's why when you compare medications to each other, please look at the definition they use for complete renal response and apply the same definition. This is more important for systematic reviews. Now, essentially, that's the highlight of this study. This study I will leave it to Dr. Al-Khalaf because he's way more qualified than me, and he will try to convince you that people should be okay to get off immune suppressive agent. I'm not sure who's sponsoring him, but this is what he can say. I will leave it for him. Now, we'll move to the next one. Next one is a little bit kind of different than the usual. So we were talking about clinical trial and medication efficacy. But one of the very important questions is what is happening in pathophysiology or biomarkers for lupus nephritis. To tell you the truth, there was nothing super exciting in this EULAR about biomarkers for lupus nephritis or the pathophysiology of lupus nephritis. This is kind of wishy-washy study, but I had to put something. And essentially, it shows the interferon signature in patients with lupus nephritis who have good response, full response, and those who had no response to treatment. And they found that patients with high interferon signature in the kidney tissue more likely to have good response to medication. Now, I think this is more related to the treatment of anti-interferon medication, infliximab or others. And this may just highlight the fact that people with very high interferon signature in the tissue more likely to respond to interferon signature, while those with low signature in tissue less likely to respond. بصراحة يعني those not the most exciting one. And that's why it didn't make it to the panel discussion anymore. The second one, splicing mechanism of leukocyte. But without going into craziness, lymphocytes have a mechanism, or white blood cells have mechanism in activating themselves. And one of these mechanisms is splicing machinery. This splicing machinery is a mechanism through which activation takes place, and different splicing machinery mechanism produce different products. And they noticed in this study that splicing machinery of lymphocytes are stimulated, perhaps partially, by the double-stranded DNA, and this can be used as a biomarker of lupus activity. So something that we might look at. بصراحة, there's nothing exciting. I don't think it will make it clear. Yes, that being said, now let's talk about more exciting one. Well, this is not really to some extent exciting in pathophysiology, and we'll get to the final study. This is just a talk about the gut microbiome. We know that gut microbiome interaction with immune system can provoke an innate response. So one of the important theory is that the gut microbiome in patients with lupus disease may change over time, and this change perhaps stimulate the the immune response. However, in this study, they looked at different disease activity state, and they looked at the genotype of the gut microbiome, particularly one particular family, Rhinococcus. You don't need to go into the details. And they found that this is highly preserved. It's not as diverse as other people, but it's highly preserved, and it doesn't change over time. And this is very important because it's just tells you that probably this is not the place to look for as a trigger for lupus nephritis. So it was kind of a negative study. Interesting for those interested in pathophysiology. I'm not sure if you guys are, but it is interesting. Now, we'll go to the last study. I hope that now you are awake and excited, because this is the second highlight of the year of the wolf, where we have a very positive results of a clinical trial. Now, this is a phase 3 clinical trial for Aurora company using a medication that is the third generation of calcineurin inhibitor. Now, the first generation was cyclosporin. Poor, let's say, has a poor safety index. And that's why we don't like to use it a lot. Tacrolimus, second generation, we spoke about it earlier, looks safe, good as an induction, maybe as an add-on therapy. But then we have the voclosporin, and voclosporin is more specific, and the more specificity you get to a calcineurin inhibitor, the more likely you have better efficacy and also perhaps less toxicity. And this is what this study was looking at. This is a phase 3 study. There was the first trial for proof of concept, second trial which was positive, and then the third trial. Now, what did they do? I'm sure that you guys are aware of it. They essentially selected patient who has been having active disease within the last 6 months, proven by lupus nephritis, and usually those people are not responding as they should with in a standard of care, that's cyclophosphamide or MMF, and then they essentially go into a randomization of either voclosporin add-on or continue on the standard of care. Now, very important, which is very important, they should be on less than 10 milligram of a steroid. And one of the primary target of all these add-on therapy, whether belimumab or voclosporin, is to show that they are able to induce remission, reduce number of flare-up with low steroid. So that's the 3 markers for lupus nephritis, for a successful treatment of lupus nephritis. And to make the story short, they randomized the patient into either BID dose of voclosporin, 23.7 milligram, plus MMF and steroid, versus placebo with rapid taper, min 20 to 25 milligram per day, week 1, and milligram by week 16. So within 3 months, you are down to 5 milligram, and 16 weeks you are down to 2.5. And this is a very important key component. The second thing, primary endpoint. Primary endpoint here, they are looking at 52 weeks. Remember, the secondary endpoint of belimumab was 52. The primary was 104 weeks, so about 2 years. But this one is a 52 weeks, so about 1 year. And essentially, the primary response, look, urine protein creatinine ratio less than or equal to 0.5. That's exactly similar to the definition used with belimumab, although the other one was 0.7. And then EGFR less more than 60%. So you have to have EGFR more than 60%. Remember, that's more or less stringent outcome compared to the belimumab one, which is nearly normal. And EGFR should not worsen by more than 20%. In the other one, they use 25%. Now, they want you to be off steroid, and there is no rescue medication, so that's more or less similar in both studies. And to make the story short, this is the results of the study in the intention to treat analysis. So the primary analysis, there was significant difference between voclosporin and control in achieving the primary efficacy endpoint. So voclosporin people, 40% respond versus 22%. That's about 18% delta, the difference, while the belimumab was about 10 or 11. But remember, you have to look at the definition, so they have slightly different definition, and also you have to look at the severity of the renal disease entering the study, and you can look at the secondary endpoint were also met for both Aurora and voclosporin and belimumab. I'm not going to go into the details of it. Please have a look. We'll wait for the result for the actual paper. They did an interesting thing here. They looked across different ethnicity. Why? They want to rub it on Roche face, because we know in belimumab the black race did not necessarily have a very good response, especially in the trial that was designated for racial specific use of belimumab. However, here in Aurora, they are showing that we worked regardless of the race. And then the last part, I'm not just going to go into this. The safety outcomes looks the same between both study groups. So the safety was essentially the same. So what I'm going to try, what I will highlight here is that this is really the year of the wolf. We had a great outbreak in lupus, lupus nephritis, and also overall lupus. Please wait for and be excited for the wonderful talk that Abdulaziz will give with very interesting studies about lupus in general. And if you have any question, let me know, and I hope that this triggered you to contribute to patient-focused research, and perhaps this will give us also a justification to do more studies in our group of people, Saudi group, through cohort studies and perhaps clinical trials. Thank you so much.
As usual, and yeah, it's an excellent actually presentation. You covered most of the important research during the EULAR. It seems that you are very excited, though still we don't have biologic this year approved for lupus, but at least we have some new things. We'll keep the question till the end of the session, so keep writing the question and we'll answer all of your questions if possible during the question and answer session. And we'll go now to the second excited lecture, which is about non-renal lupus. It will be presented by Dr. Abdulaziz Al-Khalaf. Maybe Dr. Abdulaziz Al-Khalaf, most of you knew him. He's a little bit more senior than staff in King Saud University Medical City. He's a consultant rheumatologist. He got his training the Saudi board of rheumatology from King Faisal of internal medicine, and he got the two subspecialty from Canada, from Toronto, in systemic lupus erythematosus, as well as in rheumatoid arthritis. Currently, he is the leader of the quality team in the Department of Medicine since 2016. And he is a program director of rheumatology fellowship at King Saud Medical City. He's a member of rheumatology fellowship training program committee, and he's the head of the task force of customer experience in emergency department in King Saud University Medical City. Dr. Al-Khalaf is very active in the research, and he got some publication, and he is now we'll talk about the highlight of EULAR of non-renal lupus. So the microphone for you, Dr. Abdelaziz.
بسم الله والصلاة والسلام على رسول الله. مسي على الجميع. Good evening, everyone. It's actually a pleasure to present about Best of EULAR 2020. And actually, I'm so proud, honestly, about the activity that's been conducted over the last 3 months during the COVID by the Saudi Society of Rheumatology, led by Dr. Hanan Al-Rayis and the members as well. Special thanks for my friend Dr. Faid Al-Anizi as well for his great effort actually to run this symposium. Special thanks as well for Dr. Khalid Abdul Shakur from Pfizer for as well conducting this activity. So actually it shows some of the articles that maybe has an impact on our clinical practice. So the first one is about anifrolumab. And anifrolumab, as you know, is a type 1 interferon receptor antibodies. Actually, let me just remind you about the anifrolumab is being studied in 2 trials, randomized controlled trials, TOLIB-1 and TOLIB-2. Actually, in TOLIB-1, where the primary endpoint was not achieved because I think they chose the activity index maybe is not helping them much, SRI-4, which rely more on SLEDAI 2K. However, in TOLIB-2, actually they chose the PECLA, which rely more on BILAG, which they achieved actually the primary endpoints at the end of the result. In fact, actually the study showed that in TOLIB-1 and TOLIB-2, more effectiveness on the skin, not the joints, as well as ability of decreasing the prednisone to less than 7.5 milligrams. So this is in summary about TOLIB-1 and TOLIB-2. This is a study, actually, they were looking for response over time and the sustainability of the response up to 52 weeks. In this trial, where they included 180 patients from each TOLIB-1 and TOLIB-2, and as yeah, maybe here, sorry. So as you see here, the early response was achieved in at 4 weeks in patients who received anifrolumab, and you see when they change actually the activity index or the way of definition of primary endpoints using different scoring system, they actually had in TOLIB-2 better response over time, and both actually in comparison to a placebo, achieving the sustainability response up to 52 weeks. This data actually support the sustainability of clinical derived from anifrolumab treatment for patients with active lupus. And hopefully by releasing more about anifrolumab, we'll understand more about this treatment. However, it's not yet, I think, FDA approved. So the next study, actually, let me know, I'm using maybe the space here. The next study actually from our special like lupus person, Dr. Michel Petri. And what she did actually is a smart way of telling us that we shouldn't rely much on the target dose that's been given for years from ophthalmology to treat our lupus patient. So what we used to have is a 5 milligram per kg or 6.5 milligram per kg to avoid the retinopathy that's actually happened maybe with this kind of target dose. In this study, actually, Dr. Betri included patients from her lupus cohort in Johns Hopkins, and she excluded all patients who had thrombotic events before, and she included all patients who developed VTE in form of venous or arterial. And let me just explain to you something, that hydroxychloroquine it has an anti-thrombotic effect, which actually demonstrated in vitro through restoring the anticoagulant from the action of annexin 5, which has reduced in the presence of antiphospholipid antibodies. So this is where the antithrombotic effects came from hydroxychloroquine use. So Dr. Betri, what she found in her actually results, that the rate of thrombosis was 13% lower for every 200 nanogram per milliliter increase in the mean of hydroxychloroquine level, as well as the rate of thrombosis lower for every 200 nanogram milliliter increase in the most recent hydroxychloroquine level. And what is the target over here they were looking for is between 1,000 to 1,500 nanogram per milliliter. And this is where you really trying to avoid the toxicity that can happen from hydroxychloroquine as well as the thrombosis. So again, we may, at a time that we don't rely on the target dose, the one that we usually do, 5 milligram per kg, we may end up in the couple of years now using hydroxychloroquine level, which gives us more details about hydroxychloroquine in form of toxicity as well as efficacy. So this is Dr. Betri's study. The third one, actually one of the interesting actually topic that actually is the question that we always ask ourselves about the evidence. When can we taper down the CellCept in patients who are in remission or quiescent disease? So here, this is a study, phase 2, non-blinded investigator initiated. They included 120 patients, randomized 1-to-1. They actually included patients who were on average 6 years on CellCept. Majority of them actually were lupus nephritis cases. 50% of them were having double-strand positive, and 25% of them were actually low complements. So they follow up them, they tapered them actually, they withdraw the therapy in 12 weeks time, and they follow up them to up to 60 weeks. And the primary endpoint, as you see here, the probability of a clinical significant disease reactivation by 60 weeks. So what they found, that actually, interestingly, that patients who actually in withdrawal therapy or patients who continue, actually they were having similar incidence of flare. And in fact, they found the patient who continued CellCept, they had more infection and more toxicity related to CellCept. So again, this is one of the evidence that we need to support us in tapering down the CellCept and withdrawing it over time, and feeling comfortable with withdrawing it, especially when this study showed that they were almost equal in both groups. So this is another thing that I think that we may actually need to understand, which may also lead us to change our basic workup and follow-up workup that's needed for our patients' lupus. So this is a study that the patients who were newly diagnosed, Spanish patients with the SLE, and this data came from REL's cohort. So what they were looking for, they were trying to identify the factor associated with pulmonary hypertension in a SLE patient. It was a prospective observational study. They included 289 patients, and actually 15 patients were 5.2% were having actually pulmonary hypertension. And the mean age was higher than patients who did not develop. So the mean age of patient who developed pulmonary hypertension was 56, more actually with women as well. So what they actually found as well, the baseline where those patients were having SLEDAI of 15. So they had high severity index suggestive of severe disease. And patients were actually 4 of those patients who actually had pericarditis and valvulopathies as early as the time of the diagnosis. So having pulmonary hypertension was associated with older age, as I mentioned, more dyspnea at presentation, higher ESR. Patient may have serositis at presentation, SLEDAI higher, as well as lead to a higher number of admission and actually lead to higher rate of mortality. So I think what they came up in this study, which this is what we may consider in our practice, that with a newly patient who were diagnosed with lupus, especially with severe presentation, we need to consider transthoracic echocardiogram at baseline and eventually as a follow-up. The same group actually, they were looking actually for the cardiac manifestation in a newly diagnosed patient with lupus, and they were looking for to analyze the echocardiographic features by transthoracic, as I mentioned. It's the same study and the same group of patients where they actually found that 31.5% of the transthoracic echocardiogram performed at the time of the diagnosis were pathological, mainly with pericardial effusion, valvulopathy, myocardial dysfunction, pulmonary hypertension, and myocardiopathy. So they concluded here that the transthoracic echocardiogram assessment should be considered as a part of routine examination for SLE due to high prevalence of heart disease, even in asymptomatic patients. So again, that maybe in our lupus cohort, inshallah, near future, we may need to figure out how much of our patient actually developing cardiac manifestation in the newly diagnosed with lupus. So this is another actually study where actually here this is ustekinumab. Ustekinumab has been actually studied in phase 2 in 2018, published in the Lancet journal. So actually the IL-23, it was 1223. They included in that study 102 patients, and actually 62% of those patients were achieved the primary endpoint, which was the SRI-4, versus 33% in patient on placebo. So it's monoclonal antibody that binds and neutralizes interleukin 12-23, which is an important actually in activation of kind of immune cell T helper 1, which is create an inflammatory signals that's being driven in SLE pathogenesis. So again, we are waiting for this phase 3, inshallah, hopefully near future, about ustekinumab. So what they were looking actually here in this study, they were trying to look for a gene expression. Defining the responders versus non-responders patient, and they were extracting actually blood test for gene expression at the baseline, as well as 4 weeks and 24 weeks, and as well to identify gene signature. And the recombinant IL-12 and 23 were incubated in vitro and with the whole blood from 6 healthy donors for 24 hours, and RNA sequencing was performed to determine the effect of IL-12, 23 stimulation on responders gene comprising the ustekinumab response signatures. What they found that there is 9 encoded genes that may be showing us that those patients with those 9 genes can have a better response in comparison to non-responders. So this is where we need to understand with time a gene expression and looking for responders versus non-responders in the treatment. And I think this is eventually will be future changes that happen in treatment overall. So waiting for this result to be validated actually in phase 3 trial, hopefully by the next year or the year after. So another thing that we always, I think, miss, we keep forgetting these factors and comorbid that can happen with our lupus. Unfortunately, we cannot rely on a primary care setting where they really need to work up and screen patients with malignancy. So the rheumatologists in the kingdom, they have to do everything by themselves, unfortunately. We don't have a good primary care screening patients well. So in this study, they were looking for if there is any difference between patients who had cutaneous lupus versus systemic lupus. And they included 5,310 patients from 1995 to 2014. And they were excluding as a primary outcome patients with non-melanoma skin cancer. The secondary endpoints were site-specific cancer diagnosis, including as well non-melanoma skin cancer. And they were looking for a baseline features as well. What they found interesting things that very high number actually. 35 patients with cutaneous lupus has actually a cancer in comparison to general population. 45% as well in systemic lupus may develop a cancer in comparison to general population. Actually, the most common ones actually was hematologic, lung, pancreatic cancer were increased in both groups. So the risk of many virus-associated cancer were high for patients with the SLE, like what we need to screen for pap smear as well for HPV, while an increase of ovarian cancer was seen in patients with the SLE. So again, that can always open our mind about screening our patients at the age matched group and what we need really to do for them. Another thing that's very important for a society of rheumatology in the kingdom, as well as the Ministry of Health. So what is the healthcare utilization and cost in adults with SLE in the United Kingdom? It was a real-world observational retrospective cohort where they were trying to describe the healthcare cost in adults in the UK. What from January 2005 to January to the 2017, and healthcare costs were estimated for pre and post diagnosis period for identify patients with SLE. So what actually they found that the primary care utilization was the leading component of healthcare cost during the first year of diagnosis, and this is open like a red flag for us. So we really need to educate people, educate physicians, educate as well patients about the importance of early assessment by rheumatologists, which can help us decreasing the cost as much as we can, especially that our population are young, our population are more prone to have autoimmune diseases. So it's very important to educate primary care, educating patients, educating internal medicine physician about the sign and the symptoms of lupus, which they can be referred as early as possible, which can lead to decrease the cost in the kingdom. So this one, yeah, this is again where the actually some of the study that they're trying to link the autoantibodies to response to a treatment. So in this study, they were trying to link an autoantibodies to rituximab response in a SLE patient. They included 224 patients, and they defined the clinical response as an improvement by more than 1 grade in active BLAG system with no worsening in other system. So in this, actually, they found that patients who had RMP, U1 RMP, actually, they are more prone to have a response to rituximab in comparison to other autoantibodies. With actually, it was clinically significant. So this is again open our mind about looking for autoantibodies that can predict a response to therapy. The last study is an interesting study about the sexual dysfunction in women with SLE. I thought that SLE, maybe other factors lead to the sexual dysfunction in those patients. In fact, in this study, they were it's descriptive cross-sectional study. They looked for patient for female sexual factor and index, where they're looking for sexual desire, excitement, lubrication, orgasm, satisfaction, and pain. Actually, what they found in this study, in patients who of SLE, depression and anxiety, stress were not decisive variable in sexual dysfunction. So we thought that depression and anxiety, stress is the main cause of, or actually the one cause of sexual dysfunction of lupus. Actually, in this study, what they found that the patient with no depression in comparison to control group healthy, they found that SLE patients were having more or less actually female sexual dysfunction factors, as well as patients with no anxiety and no stress. So it was actually the prevalence of sexual dysfunction in SLE patient was high. Depression and anxiety, stress were not decisive variable in sexual dysfunction. I think what I need to change in my clinical practice, that we may need to refer patients with SLE to a women health specialist, that they can help them diagnosing some of the major actually problems in their quality of life. And conclusion, anifrolumab actually showed an early and sustained response in TOLIB1 and TOLIB2 up to 52 weeks. I think we need, in near future, we may change our target of hydroxychloroquine dose from 5 milligram per kg to 1,000 to 1,500 nanogram to prevent thrombosis, as well as looking for toxicity. Withdrawal of MMF was successfully done in the trial that I showed, especially if the patients are in quiescent condition for years. Pulmonary hypertension and cardiac manifestation in early presentation of lupus need a baseline workup in form of transthoracic echo. And this is another thing that we may need to change our clinical practice with. Finally, patient of SLE or cutaneous lupus, they carry risk of cancer, and we need to look for and screen them for cancer as well. Early diagnosis of lupus reduced disease severity as well as the high healthcare cost associated with lupus. Rituximab responders had a higher frequency of anti-URMP compared with non-responders. Finally, an SLE patient who actually having actually an SLE patient, actually depression and anxiety, stress were not the major play role in the sexual dysfunction that can happen with lupus patient, and this is also need an early referral for a women health care specialist. Thank you so much.
Thank you, Dr. Abdulaziz. Again, excellent lecture, excited knowledge. We can open the session for question and answer. We have actually a couple of questions for both Dr. Ibrahim and Dr. Abdulaziz. We'll start with Dr. Ibrahim. Dr. Ibrahim, regarding lupus nephritis and this medication, like what they wrote here, who's supposed to follow and treat lupus nephritis, particularly it is the only major organ involvement, though this is not part of the abstract. So we'll go to the second question regarding BLISS lupus nephritis trial. It was only for adults, isn't it? For adult patients. So did they mention anything about age group in the study?
Yeah, so I will answer two questions. We'll start with the second. The study inclusion criteria include patient 18 and above, so it was not meant for pediatric group. However, I think they are trying to explore this option in pediatric group. يعني, as far as I know, if you look at clinicaltrial.gov, you will see the registered trials for such thing. The second question with regard to lupus nephritis, there are two approaches. One is rheumatologists treat everything, get going, and there is another approach where a nephrologists do it alone, and there is the combined clinic. And obviously, the combined clinic is much better because of two things. One, because of looking at the extra-articular manifestation. People with nephrology, they don't have the time to actually look at all the other systems, and that plays a role in the treatment decision. And two, sometimes we see a lot of a trend from rheumatologists to use higher doses of steroid, and I believe that the presence of nephrologists always remind them that we need to cut down. It is okay to tolerate some proteinuria. So I think the best model is the combined clinic model, if you can, or in close relationship with the nephrologist, and we do that in our lupus clinic, specialized clinic in Kingsford University, me and also.
Great. There is another question about tacrolimus. For how long in that cohort they continue tacrolimus?
Yes, so that's a very good question. So the study was meant for a year or so, the induction, and then they switched. So they induced with tacrolimus versus MMF, and then they switched to Imuran as a maintenance. However, in some group, like small proportion of patients, they added tacrolimus to either crossover, but mostly to either group. That's an open phase, which is within the 10 years follow-up. The proportion was small, and again, the outcomes seems to be very similar in both groups. So you can use, and that was reflected in EULAR recommendation, you can use tacrolimus as an option of induction. Personally, based on the available data, I would not use it unless you are an aging country or very aging population. I wouldn't use it for induction. However, as a maintenance, as an add-on therapy, we have good safety data over 10 years that suggest that perhaps using calcineurin inhibitor is not necessarily associated with a lot of kidney toxicity. I have to warn you for one thing, that those patients were induced, not maintained. Not the majority of them were maintained, and hence the biopsy of a patient who flared reflects mostly induction. So whether there is a continuous effect of tacrolimus, which we know on the tubules and toxicity in the kidney, this study was not meant to show. And perhaps most of the safety signal will be addressed through voclosporin, which seems to be much more reassuring from a safety perspective.
Great. I have a question for Dr. Al-Khalaf regarding withdrawal of MMF. The question was when and how medication can be withdrawn according to the study.
So the study actually, first of all, they included all patients who were actually in lupus in remission, and they were on suscept for 6 years actually, the average, and the tapering was over 12 weeks. This is the way that they conducted the study, and they succeeded actually in this result at the end.
Okay, great. And regarding the study of hydroxychloroquine level, did they mention whether they check the peak, trough, or random level in the study?
I'm not sure about this, to be honest, but I think what they do at the trough level actually. Yep.
And they mentioned here regarding when they discontinued MMF, did they started any other DMARD or just withdrawal?
No, just black and yeah, yep. That's it.
And they didn't mention anything regarding steroid in this discontinuation?
They included all patients on less than 7.5 milligrams.
Great. Here is another question for you, Dr. Abdulaziz. Did MMF withdrawal include patient with CNS lupus or lupus myocarditis patient? Did they specify or just?
No, they didn't specify, but actually the majority were lupus nephritis cases. This is what they mentioned in the study.
Okay, so they didn't mention anything regarding the severity. Okay. They mention here about a very interesting result about the prevalence of pulmonary hypertension in the Spanish cohort. The question was, how severe was it? Did they mention about the severity of pulmonary hypertension in this study? And they mentioned to highlight the result. Did this result was confirmed by right cath? Did they confirm it? To confirm the diagnosis, or just transesophageal?
This is transthoracic. 15 patients actually. The pulmonary hypertension actually was around 49. This is what they found.
Okay, so their conclusion in the study to recommend screening investigation for specific by like heart echo, ECG, or chest X-ray.
So what they came up that there are predictors that you need really to investigate those patients definitely. And those patients who are like old in age, like above 50 maybe, patient who has severe disease at presentation of SLEDAI of more than 15, having another sort of I forget what other predictors, but in fact, actually, what they conclude that for those patients that you really need to screen them. But in the other study where they looked to cardiac manifestation, actually they included all patients, and they said that majority, 31.5% of patients who were screened at the baseline actually had a cardiac presentation with no symptoms.
Okay, and they didn't mention anything regarding screening. How frequent?
No, what they did, they did the baseline. But I think if you do have something at the baseline, this is the time that you really need to consult cardiologist, and they keep following them up annually, maybe.
And again, even in our practice, I mean, we used to do the basic echo, ECG, chest X-ray, and then according to the patient's symptoms, we didn't do it, I mean, frequent like in scleroderma.
But here, Hanan, they included, was their conclusion that those patients are asymptomatic.
Yep.
So this is the important message, that we may need to screen patients at the baseline, even if they are asymptomatic, and this is we need to understand from our cohort, inshallah, near future.
Yeah, this what I mentioned. Even I used in my practice to screen all of my patients as a baseline with echo and ECG, chest X-ray at presentation, and then if the patient's symptomatic. But baseline, I used to do it. Some of the rheumatologists, they did the same. Here, the question regarding these two studies, two new medication, and they added to the standard of therapy. So the question is, what is the opinion about giving investigation drug in addition of standard therapy, which could include MMF or cyclo, and the effect of this drug might be the result in a negative study. I mean, could be just related to the baseline. So anyone can answer this.
That's a very good question. Sure. So that's a good question, and that's the reason why we have a placebo. So remember, those patients, so the challenges, when you have, as we know, when we have a lupus nephritis, we try to achieve certain outcomes. So remember, from the EULAR guidelines or from the teaching or from the whatever, the target of treating lupus nephritis is that you want to have a complete renal response if possible, and that means that you have less than 0.7 at least over 12 months of 24-hour protein collection, less than 0.7 gram or between 0.5 to 0.7, and you want to have near normal creatinine. Okay, so that's the primary target. Now, assume that you fail to achieve this target. Usually, we hope or aim for over the 6 months, sometimes to have at least 50% improvement. So let's say that you were not able to achieve this target. The question then is what should you do? And the use of these medication, that was the rationale of using these medication, because they want you to be off steroid and they want you to achieve the target that will have a good long-term outcome, i.e. less progression to end-stage renal disease or chronic kidney disease. Now, the whole purpose of having placebo arm is that you look at the effect of the add-on medication compared to the standard of care. And that's why perhaps you see that the efficacy, the amount of effect is not huge. So about 10% in belimumab, 18%, that's relatively good. That's an add-on to the treatment effect of MMF or cyclophosphamide followed by Imuran versus MMF followed by either Imuran or MMF. So this is one benefit. So that's the whole idea of having placebo.
One thing regarding tacrolimus study, did they mention that any monitoring for tacrolimus level?
Yeah, so they don't monitor strictly the level compared to the cyclosporine. So the tacrolimus has more stability in terms of the level. They did that early on in the induction therapy, remember? And what they are doing here is just the long-term outcome, 10 years outcome of those who were induced by tacrolimus. So they don't necessarily do it. In other studies, when they look at tacrolimus, it has a stable level, and that's usually reflected in the transplant literature, and that's why they don't do a lot of levels for tacrolimus per se, unless they have some start to see some toxicity, elevated creatinine or something, when you look at the level.
Again, there is a question about did they involve lupus nephritis in the withdrawal study, Dr. Al-Khalaf? Yes, it was. They include them. And the other things regarding the MMF study, withdrawal of the MMF, they asked for your opinion regarding whether to wait till we discontinue steroid first, and if the patient in remission, then we can discontinue MMF, because we know that the main side effect of steroid on long term on patient is mainly steroid. So if our patient in remission while he's in MMF and steroid, so our first target is to taper steroid to zero if possible, and then if the patient in remission, then we'll start withdrawal of MMF. So what is your opinion, and did they mention anything about this in the study?
No, actually, it was not mentioned, but in fact, actually, if you look to the most recent study about the tapering of the steroid and the risk of a flare in patients with lupus who were actually less than 5 milligrams in comparison to people who stopped the steroid, prednisone. Actually, we know that from this study that our patients are too fragile to taper and wean off them of steroid. It's very challenging. And the toxicity with the long term that with the Silsibt may be more rather in form of infection. And we know that Silsibt, among other DMARS therapy or immunosuppressive therapy in lupus, especially the first line, the highest among them with a risk of infection. So I think we really need to taper those patients as soon as they are in remission, and the way that they did it, it's actually great.
Excellent. So now we are ending this session. Thank you again for both of you. Excellent review. And now we'll have a 15-minute break. So just I want to remind the audience that they have to write their evaluation for the session as well as the speaker, and to be back after exactly at 8:45. So take your coffee during this break. I wish that we are together, so we'll go to the coffee break. Inshallah, we'll be away from this COVID-19, inshallah, in the near future. Thank you again. And do you have anything to add, or we'll close the session?